The following podcast is part of a certified educational activity titled The Future Looks Bright for People with Fabry Disease, Improving Diagnosis and Expanding Treatment Options. Access the entire activity and complete the post-test at peerview.com/ZTU860. Downloadable slides and practice aids are also available.
Hello, this is David Warnock speaking. I'm a professor of medicine emeritus at the University of Alabama at Birmingham, and I've been taking care of Fabry patients for the last 21 years. Today I want to share with you some thoughts we have about our current approach to the diagnosis and treatment of Fabry disease, and I hope you find this informative. Fabry disease is an X-linked, inherited disorder of lipid metabolism resulting from deficient activity of the enzyme alpha-galactosidase alpha. Although it's X-linked, in 2001 it was recognized that women and girls can also have this disease, have symptoms and clinical findings. The enzyme deficiency causes a continuous buildup of global triacylceramide, GB3, and related glycolipids in the body's cells, resulting in cellular abnormalities and organ dysfunction that particularly affect the heart, kidneys, and nervous system. Fabry disease is the second most prevalent lysosomal storage disease, just behind Gaucher disease. Let's consider the diagnosis and management of Fabry disease. Given the progressive nature, early diagnosis is important, but is often missed or delayed by up to 20 years after symptom onset, leading to untreated disease and cardiac, renal, and nervous system damage. Women are often misdiagnosed as having lupus, fibromyalgia, or other conditions. If clinical examination raises a suspicion of Fabry disease, the diagnosis is confirmed by demonstrating the enzyme deficiency in men and by identifying the specific GLA mutation in men and women. A white blood cell alpha-Gal A enzyme level, available through many reference labs, can be helpful, especially in males, as part of the initial evaluation. Management of Fabry disease requires a multidisciplinary approach, including a host of specialists because of the protein nature of this disease. Fabry disease is treated with supportive care and disease-modifying treatment, including enzyme replacement therapy and chaperone therapy today. The spectrum of Fabry disease, symptoms, and severity is very important to understand. In the classic Fabry disease, little or no alpha-Gal enzyme is produced, and child onset of symptoms is very common. Severe morbidity with multisystem manifestations is the usual finding. In non-classic Fabry disease, there is residual alpha-Gal activity, so the onset of symptoms is delayed, and the phenotype, in fact, can be milder than we see in the classic presentation. You see in the cartoons on the left with classic children, chronic fatigue, recurrent fever, cold and heat intolerance are very important early findings. And in the males, especially on the right, in the adults, left ventricular hypertrophy, arrhythmias, autonomic dysfunction, proteinuria, progressive loss of kidney function, angiokeratomas, and edema are important findings. Neuropathy in Fabry disease presents a wide spectrum of severity, both in males and females. Proteinuria is a very important manifestation of podocyte injury and is strongly associated with progressive loss of kidney function. The overall rate of progression of chronic kidney disease resembles that of diabetic nephropathy in classic males. Untreated males frequently develop end-stage renal disease in their 50s or even younger. Classic patients with Fabry nephropathy who develop renal failure frequently suffer concurrent symptoms from other major organ systems. Pediatric signs and symptoms are very important. Can be hard to detect because several of the signs and symptoms can overlap with other conditions. However, in children's, pediatricians and family practitioners should be alert to acute, unexplained episodes of pain, often accompanied by fever and unresponsive to usual analgesics. Heat, cold, intolerance, exercise intolerance are important findings. Angiokeratomas, which are spotted dark red skin rashes, are most common between the umbilicus and the knees. The photo shows small angiokeratomas on the scrotum of an 11-year-old male with classic Fabry disease. Children often have unexplained frequent gastrointestinal disturbance, diarrhea, vomiting, nausea, abdominal pain, even constipation. Hypohidrosis, troubles with sweating, an important finding, mild proteinuria, and of course the sex differences need to be emphasized. There's a lower prevalence of symptomatic disease in females than in males. Males experience a younger age of onset of symptoms than the females, 6 versus 9 years typically. This is a diagnostic algorithm for Fabry disease. It's a targeted approach. Testing in males and females with suspected disease can start with the enzyme activity, although in females this can be less helpful than it certainly is in males. However, GLA genetic testing for the specific mutation is required, in my opinion, in all patients. A challenge is presented if the patient has a mutation of unknown significance. Does this cause disease, or is this a benign polymorphism? What's important is to assess the patient very carefully for associated system organ damage. Is there renal function decline? Is there increased urinary protein, albumin, with respect to their creatinine ratios? What about the plasma GB3 and the plasma lyso GB3? These can be very helpful in patients with unknown variants that have not yet been described. What's the ultimate gold standard, of course, is tissue biopsy, showing intracellular GB3 inclusions. Very, very important. Newborn screening for Fabry disease is a new development. The best way to detect Fabry disease is at an early stage. It has high sensitivity, but varied specificity depending on the screening technology that used. Now, it's not included in all the newborn screening panels, but it does happen in Delaware, Illinois, Missouri, New Jersey, Pennsylvania, and Tennessee, and other states are coming on board. Now, early treatment with available therapy can prevent disease progression and improve quality of life. More importantly, in my view, the entire family should then be screened for that mutation found in the index case, in the neonate. Genetic testing and family planning are important in considering this disease. Genetic counselor, medical geneticists are helpful in identifying other affected family members, addressing psychosocial issues and economic insurance issues and so forth, and also referral to various support groups. Preconception prenatal counseling is useful. Remember, this is an X-linked inherited disease. That means women will pass the mutation off to half of their children, and males, of course, will only pass the disease on to their daughters. They don't give the son an X chromosome, so the son will never get Fabry disease from their father. Prenatal genetic diagnosis is possible, but rarely needed. Surrogacy is a relevant option, especially in women who desire to have children, but already have advanced kidney involvement. Complications can occur during pregnancy. Increased symptoms, proteinuria, GI problems, acroparesthesias, and the kidney disease can progress during pregnancy. But you know, this is a problem with all forms of chronic kidney disease. We're turning now to module number 2. We're going to focus on the therapeutic strategies and emerging new treatments for patients with Fabry disease. ERT, enzyme replacement therapy with Migalastat alpha or beta, can slow the irreversible damage in renal and cardiac systems if it's started at an earlier stage of the disease. It may slow progression or development of extrarenal signs and symptoms and improve quality of life, even in patients with end-stage renal disease. However, we have to understand that it's less efficacious if we wait to start treatment until the disease is advanced. Migalastat, chaperone therapy, is useful. We'll spend some time discussing this, but it's only available for adult patients who have amenable mutations. Emerging therapies are worth mentioning in passing: gene therapy, new ERT preparations, as well as substrate reduction therapy. It's important to emphasize that adjunctive supportive therapy for management of chronic kidney disease and cardiovascular risk factors is also necessary. We need to reduce proteinuria, control the blood pressure, control the lipids, treat hypercoagulability as part of the standard of care for patients with Fabry disease. This schema organizes our thinking about the therapeutic approaches for Fabry disease. Early on in the processing of the protein, we can talk about gene therapy. The intention here with various approaches is to improve the availability of enzyme. This can either be liver-targeted therapy or cardiomyocyte-targeted therapy, but the exogenous DNA information is either added to cells that are transfected and targeted to the liver or directly. We have a problem with protein folding. Many missense mutations do produce protein, but the protein is not active, and chaperone therapy may be helpful in a subset of these mutations to develop and present a properly folded protein with good action. Enzyme replacement therapy is currently the mainstay for most patients who have Fabry disease. This can include the PEGylated Alfa as well as the PEGylated beta preparations, and an investigational product, Pegunigalsidase Alfa, is also in late development for Fabry disease. We're going to also talk a bit about substrate reduction therapy, shown on the left of this slide, but we'll detail this in a further cartoon. This is what enzyme replacement therapy does. This is a product that was approved by the FDA in 2003, PEGylated beta. It's given every 2 weeks at 1 milligram per kilogram, and it effectively reduces plasma and tissue GL3 levels in the vascular endothelium of the kidney, skin, and heart, which at the time of the conditional approval was accepted as a surrogate marker for clinical benefit. You can see the heavy lysosomal deposits on the left, and after 6 months of treatment, you can see that these deposits are greatly improved. What about kids? When are we going to start treatment with enzyme replacement therapy? The presence of symptoms in boys and girls with classic mutations is a strong indication for the early initiation of enzyme replacement therapy. Treatment should be initiated before irreversible end-organ damage has occurred. Asymptomatic children with Fabry mutations should be followed closely for the development of renal, cardiac, neurologic, and gastrointestinal signs and symptoms or laboratory changes which would warrant treatment initiation with ERT. I'll remind you that Migalastat, chaperone therapy, is not approved in pediatric patients. What about adult males? Well, let's start with the classic patients. We consider enzyme replacement therapy in all male patients. PEGylated beta is given intravenously at 1 mg per kg every 2 weeks in the U.S. and outside of the U.S., and the PEGylated alpha is given at 0.2 mg per kg every 2 weeks, only in countries where it is approved, which does not include the U.S. ERT slows progression of disease, particularly in those diagnosed and treated at earlier stages. Males with late-onset Fabry disease would start ERT if there are laboratory, histologic, or imaging evidence of kidney, heart, or CNS damage. If the GFR is less than 90 mils per minute, adjusted for age, or if there's persistent albuminuria, the renal biopsy shows podocyte foot process effacement, glomerular sclerosis. The brain MRI shows signs of stroke or white matter lesion, or if there's significant cardiac involvement, with cardiomyopathy, arrhythmias, cardiac fibrosis, and MRI. These are reasons to start enzyme replacement therapy in late-onset variants. Migalastat is limited to patients who have amenable mutations. How about adult females? In symptomatic female patients, ERT is started if there are signs or symptoms of organ involvement, neuropathic pain or neuropathy, symptomatic cardiac disease, not from other causes, proteinuria, albuminuria, not from other causes, evidence of renal impairment, GI dysfunction, exercise intolerance, impaired sweating. Asymptomatic female patients can start ERT if there's very convincing evidence in the lab or imaging studies for heart, CNS, or kidney involvement. Significant cardiac involvement would be more typical in females with late-onset variants. They have cardiomyopathy, arrhythmias, cardiac fibrosis on MRI. Do they have persistent albuminuria? Do they have podocytes, effacement on kidney biopsy? What about evidence of brain involvement with white matter lesions or a history of stroke or other signs of neurologic involvement? Again, migalastat should be considered only in patients who have amenable mutations. There are limits to our current use of enzyme replacement therapy. There's no evidence for benefit regarding cardiac arrhythmias or conduction abnormalities, possibly due to the late initiation of treatment or inadequate current dosing availability. There does not seem to be any effect on preventing ischemic stroke. Unfortunately, there are cross-reacting antibodies, anti-drug antibodies developed in classic male patients that can alter the tissue distribution, cellular uptake, and efficacy of enzyme replacement therapy. Pegyilated beta is approved and widely available. Pegyilated alpha is not approved in the US, but widely available elsewhere. The late-onset variants can be treated if the mutation is amenable with chaperone therapy. Migalastat is improved in the US for treatment of adults with amenable variants. Less than 50% of the patients will have such variants, and this amenability is determined by in vitro pharmacogenetic assays, and those results are easily available. The drug is given orally every other day at 123 milligrams dosing. There are two trials that are important in the history of the development of migalastat. The Attract trial was in patients who are already treated with ERT, and the co-primary endpoint was achieved, which was basically continued stabilization of the renal function. The Facets trial was done in enzyme-naive patients, and with various approaches to the definition of amenability, the drug did in fact reach its respective primary endpoint, stabilization of kidney function, with an open label extension showing that this was well maintained in patients who did not have severe proteinuria. What we don't know is data concerning major kidney events in patients with severe renal impairment, because the drug is not given to patients who have GFRs less than 30 mils per minute. EMA, the European Medicines Agency guidance, is recommending monitoring the renal, cardiac function, biochemical markers every 6 months. The US guidelines have not been updated yet to include migalastat. Pegunigalsidase alpha, PEGylated ERT, is a new development. All the trials have been completed. I'll summarize those for you on this slide. The phase 1-2 study, 18 patients, open label, 3 to 9 months, and importantly, biopsies were included that showed clearing of the intracellular GB3 deposits. The open label Bridge and Bright studies were essentially switch studies. The Bridge study was a switch of patients on Pegunigalsidase alpha who were switched over to Pegunigalsidase alpha. The preparations were given every 2 weeks, and again, this was an open label switch study. The primary endpoint was really a safety assessment, and the number of adverse events was a very good profile. Annualized changes in GFR seemed to be improved, but the primary endpoint was a safety one, and that was met in this study. The Bright study was a very interesting study, 12-month duration with an open label extension. 30 patients were enrolled who were currently on full dose Pegylate beta at 1 mg per kg every 2 weeks. They were switched, open label, to Pegunigalsidase alpha at 2 mg per kilogram given every 4 weeks. The primary endpoint again was a safety study in this open label study, and it appeared that the number, severity, and nature of the adverse events on the new treatment was very complementary to the outcomes. The secondary changes in GFR, plasma levels, and so forth of GB3, lyso-GB3, all of these were compatible with adequate treatment with this new preparation. The interesting, most recent study, soon to be published, is a randomized controlled trial. 78 patients with progressive loss of kidney function on current enzyme replacement therapy were randomized, and 2/3 of them were switched to Pegunigalsidase alpha. 1/3 continued on their current ERT, but in a blinded fashion. The infusions were given every 2 weeks at a complementary dose to the control, and the primary outcome was a comparison of the annual median eGFR. The change in GFR was the primary endpoint, and in this study it was designed as a non-inferiority study, and that primary as well as the other secondary endpoints were met. This is an example of the balanced study, the primary efficacy data, showing the eGFR slopes over the 2-year duration of this study. You can see the patients had definite kidney involvement, and the patients did as well on Pegunigalsidase alpha as they did compared to the patients who continued in a blinded study on the Pegylate beta. This met the medium slopes in the bottom table, which showed that there was no difference in slope over the 2 years of this study. So this was a successful outcome for comparison of Pegunigalsidase alpha to the approved Pegylate beta. It showed non-inferiority based on the median eGFR annualized slope, a key measure of Fabry disease progression. No new safety concerns were identified. Overall, the tolerability and immunogenicity profiles were favorable for patients who were switched to Pegunigalsidase alpha. The rate of treatment-related adverse events was approximately 1/4 lower in the treated group compared to the standard Pegylate beta group, and the proportion of anti-drug antibody patient with neutralizing antibodies was actually lower in the patients on the Pegunigalsidase alpha than Pegylate beta at the end of the 24-month study. The event rate and infusion-related reactions approximately 8-fold lower in the new treatment group. Most patients opted to continue after the study was concluded in the open label extension study, which will go on for another 60 months. Let's talk about substrate reduction therapy. The metabolism of the ceramides is shown on the left, and there are 2 steps that we can consider. The first is the glucosylceramide synthase enzyme. That is treated by 2 agents that are currently in clinical trial. There's a third agent that has recently been reported in animal studies and cell culture studies, which inhibits the final enzyme that converts GB2 to GB3. All of these agents would be expected to reduce the amount of GB3 accumulating in the lysosomes by simply reducing the amount of substrate. The clinical trials are ongoing. We'll see if there's a role for SRT in treating Fabry disease in the future. Gene therapy studies at this point are very preliminary. This is a slide that shows the plasma alpha-gal activity in 5 patients who received enzyme replacement therapy. In general, it does appear that at least a transient and hopefully permanent increase in plasma activity can be achieved, but I have to tell you, in my view, these results are too preliminary at this point to make any sort of a strong conclusion. There is an open label study with a product that targets the cardiomyocytes. And again, this seems to be well tolerated. The primary and secondary endpoints are being studied. There are no dose-limiting toxicities reported at this point. It shows promise in treating Fabry disease in both ERT experienced as well as patients who have antibodies to ERT. But again, this is very early on in the development of this program. There's another trial with a drug. This was so-called MARVEL trial. It's an adenovirus-associated approach with a rational design for including the GLA and under a liver-specific promoter. Open label studies again, phase 1-2. Primary endpoint is safety. At this point, I think the safety seems to be reasonable. But we don't have efficacy data at this point that's conclusive that would lead to a phase 3 study. It is worth noting that one of the gene therapy programs has been discontinued. This was an agent being developed by AvroBio, and according to their press release in January 2022, this development program was discontinued because of apparent futility. The project new clinical data showed variable engraftment patterns in the most recently dosed patients, which would extend the product's development time, and the program was discontinued. Finally, I want to emphasize the importance of all the adjunctive supportive treatment and management in Fabry disease. We have enzymes and we have Chaperone. We hope to have substrate reduction therapy that are disease specific, but in addition to that, we want to address neuropathic pain. We want to address the stroke issues. We want to address depression. We want to provide the standard of care for patients who have chronic kidney disease. Patients need to have their blood pressure controlled. The arrhythmias are important, and even implantable pacemakers or defibrillators have been used to treat this condition. Bradycardia is an important issue, and pacemakers are very helpful. Heart failure is something to be aware of. Coronary disease is not typical of Fabry disease, but can develop and should be treated appropriately. Lipid issues are addressed with the statins. The smoking is obviously a problem. The GI issues can be helped with various approaches, dietary as well as H2 blockers and so forth. And importantly, hearing loss is a very bothersome finding when that develops, so hearing aids and even cochlear implants are useful. Follow-up and monitoring is important. We need to assess patients for cardiac involvement. Hypertrophy and cardiac death from arrhythmia is probably the most common cause of death at this time, especially in males. We know that the QRS duration is important, and the left ventricular mass index is an important variable. Renal involvement and progressive loss of kidney function have to be detected, monitored, and addressed. Follow-up in terms of the U.S. guideline is annual follow-up with the renal assessments to consider echo and electrophysiology every 2 years, annual pain, GI, quality of life evaluations, and the renal biopsy is, in my view, very helpful in problematic patients or in patients who are being considered for a change in therapy. Strategizing for personalizing treatment is very important. These issues include patient-specific characteristics such as their family history, age, sex, genetic testing results, mutation type. These personal issues can impact on treatment decisions, the initiation of treatment. When to use ERT, when to use Migalastat can be important questions. The patient's choices and participation are very useful. The treatment, when to start and the modality of treatment is a very personal decision and has to be carried out on a case-by-case basis. In conclusion, Fabry disease is a rare X-linked lysosomal storage disease. It can affect women, although the phenotypic variability is notable in women. Diagnostic delays up to 20 years can be a problem in terms of initiating treatment. Hopefully, new testing approaches and newborn screening will address this diagnostic delay. Kidneys and cardiac sequelae are a common feature, especially in the classic form of Fabry disease. Treatments should be initiated before permanent organ damage occurs. We know that ERT is highly effective in stabilizing the patient's condition. We know that Migalastat is highly effective, although its effectiveness is limited to patients with amenable mutations. New treatment options are on the horizon. That's very good news for the Fabry patients as well as the treaters. Finally, Fabry disease requires lifelong management and monitoring. I hope these presentations have been helpful to you, and I appreciate your attention. Thank you very much.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/ZTU860. This activity is supported by an educational grant from Chiesi USA Incorporated.